This is Chapter 36, Multisystem Trauma and Special Populations. So what it really comes down to with traumatically injured patients, when we talk about multi-system trauma, what we mean is more than one organ system is affected. So if someone falls and bumps their head and has a brain injury, that's of course serious. But if they have a brain injury and then they have a thoracic injury and then they have a pelvic injury, and you get the point here basically, the more systems that are involved in the process, the greater the chance this person is probably going to die. So when someone says they have a multi-system trauma patient, it means that they're very critical, or the potential for being critical. And ultimately, outside of the ABCs and outside of the basic life support that we provide these people, our best treatment is early recognition and rapid transport. Don't take the long way to the hospital, basically, and take them to the right hospital, a trauma center. Now, obviously, you've learned about scene safety and all different kinds of situations that might occur. Of course, resources are many, anything from low-angle rescue to high-angle rescue to helicopters to rescue vehicles to ambulances, all those great things. And when you go on scene to some type of accident and you have someone who's been traumatically injured, understanding how they were injured and what areas of their body absorbed the energy will tell us a lot about what their potential injuries could be. Because remember, even though the person might have an amputated leg and they might have obvious abrasions to their head and to their chest and all that, we can't really look inside. We can only speculate that this person has serious internal injuries based on their vital signs, their presentation, and the MOI. So when you arrive on scene, your goal is to get off scene as soon as possible. So have somebody hold inline stabilization. If they need oxygenation right then and there, BVM ventilations right then and there, well, then go ahead and start them. If they're squirting blood, stop the bleeding, but that's about it. The rest of it is going to happen in the back of the ambulance on the way to the hospital. Now, this is the best way to treat these people. It's called diesel therapy. You put them in the back of the ambulance and you just go, and you drive to the hospital, the appropriate hospital. En route to the hospital, you'll do those things you haven't done yet. You'll get a blood pressure, you'll check a pulse, you might do some suctioning, you might splint a leg, but ultimately our goal is to treat the ABCs and then just get them going towards the hospital. Don't dilly-dally at scene. Now we have this special population of people that are pregnant. Now what happens in pregnancy is the obvious, of course. There's now technically two patients, if you think about it, but there's anatomical changes and there's physiological changes to the mother. So anatomically, as the pregnancy passes through its gestational period, the first trimester, the second trimester, and the third trimester, as this patient's abdomen grows in association with the growth of this child, their balance changes, their organs literally in their abdominal cavity move around, their bladder moves kind of out of the way. All these things, these anatomical changes, makes this person, one, more prone to fall, because if you think about it, if you're in your third trimester, you're 8.5 months pregnant, and you've got this really big belly. You can't see your feet, your center of balance is off, and they're prone to fall. If they fall forward onto their stomach, they can harm the child and cause internal bleeding. Also, their pelvis towards the end of the pregnancy is not quite as stable because it's starting to spread a little bit to allow that child to pass through the birth canal during the birthing process. And then physiologically, women add about half more blood volume during this period of time as they're going through their pregnancy. They breathe faster, their pulse is higher, their oxygen needs are higher, their glucose needs are higher, and all that. So when someone's injured, like you see in this picture right here, and yes, according to the picture here, this person has an open tib-fib fracture and it's bleeding and it's a concern, but remember, there's two patients. So these two EMTs are doing the right thing. One's controlling the C-spine and the airway, and the other one's treating the bleed. But this patient needs to get off the floor and get to the hospital quickly as possible because there could be some type of internal bleeding going on due to the child being involved in some kind of blunt force. So when a patient becomes pregnant and the fetus starts to develop, along with the fetus, the placenta develops as well. Now, the placenta is a solid organ. It adheres or is attached to the uterine wall, and it's basically the baby's life support system. This is where the baby gets all its oxygen, its nutrients, its sugars, and all of its waste products are removed through this umbilical cord. Basically, it's your belly button after you're born. So there's this condition called abrupto placentae, and so this means a very sudden release or freeing of this organ from the wall of the uterus. And this is usually occurs due to trauma, blunt force trauma to the abdomen. I've seen these in car accidents. Patients aren't wearing their seatbelts properly, and the seatbelt kind of pushes in, and it causes this abrupto to occur. Falls like this. I had one lady years ago. I think it was her boyfriend or her husband wanted to abort the child, and he wound up kicking her in the stomach multiple times. And of course, he succeeded, unfortunately. The problem with this is that two really bad things. One, remember this is the uterus is very, very vascular, lots and lots of blood. The mother is essentially feeding the baby. So if this organ dislodges, if this abrupto placenta occurs, then the baby's not getting oxygen, not releasing waste products. And the problem with these infants that are in womb like this is they kind of have a reverse nervous system. So unlike you or I, if we were losing blood or we were hypoxic, our heart rate initially would go up, like we've learned already. But these, what we call neonates, or these infants that haven't been birthed yet, when they become hypoxic, their heart rate drops dramatically. And if this child's without oxygen for 30 seconds, a minute, a couple of minutes, they can die within a few minutes of this occurring. So it's really important that we have a high index of suspicion. Anytime we have a female patient who is pregnant and they've had some kind of traumatic injury, whether it's a car accident or a fall or an assault, even though they're stable and they have no outward signs of trauma about them, and they say they're fine, they still need to go to a trauma center and get an ultrasound to their abdomen to make sure that there's no abrupto occurring. Now, treatment for this lady here on the floor, she does need spinal motion restriction. She fell down that flight of stairs. She has a distracting injury, and we are going to put her on a spine board. But what we're going to do is, because we want to take the weight of the baby off of the patient's vena cava, one of the biggest problems that we have with patients that are especially in their third trimester, so basically after about 20 weeks of pregnancy or so, or beyond, like that, maybe second, third trimester, is when the patient lays supine, the weight of the baby presses down on the vena cava, the inferior vena cava. And remember, the inferior vena cava takes blood back to the heart to get pumped out. So if you're squeezing the vena cava and less blood is getting back to the heart, less blood is getting pumped out, and it causes hypotension. This is called supine hypotension syndrome, and it's fairly common in this situation. So pregnant patients are encouraged by their physicians to not sleep on their back, to sleep on their side. And if we're going to transport them, even if they're not injured, let's say this lady has a fever, she has some kind of medical problem that's not unrelated to any traumatic injury. I'm still going to put her on her left side for two reasons. One, if I put her on her left side on the gurney, she'll be facing me on the way to the hospital because I sit on the right side of the ambulance on the way to the hospital on the bench seat. And also, the left side is the most efficient for taking the weight off of the vena cava. Now, obviously, this lady here, she needs to go into some kind of spinal motion restriction. And I still want to tilt her, but I want to maintain some kind of neutral spine. So we are going to use a spine board on here. We're going to pad the spine board with a blanket. We're going to put her onto the spine board. We're going to strap her to the spine board as appropriate with a collar in place and head blocks and whatever your agency might need to use. And we're going to put her on the gurney, and then we're going to take some rolled blankets, and we're going to place him under the right side of the board, causing it to be tilted about 6 inches to the left. So the County of San Diego S139 says that we tilt these patients 30 degrees to the left, and that's approximately about 6 inches. If you raise the right side of the board 6 inches, you've got pretty much about 30 degrees or so. And then you're going to rapidly transport them to a trauma center for evaluation. Again, that's for someone who needs spinal motion restriction. If they don't need it, then put them on their left side. And the county, I believe, says any patient who is greater than 20 weeks in gestation, so they're greater than 20 weeks pregnant, should go onto their left side during transport, even if they're medical patients. Now, pediatrics have their own little considerations. The number one consideration for pediatrics is our response to their injuries. And you'll see this if you don't have children, if you do have children, I don't know. It doesn't seem to really matter. I've noticed that first responders and EMS personnel and fire personnel and even hospital staff really get amped up when a child is seriously injured or seriously ill. So that's the first thing you got to think about is, how are you going to respond to this child's illness or injury? And you need to calm yourself down, think with your brain and not your emotions. It will help a lot on these calls. Kids do regress. You get a 7-year-old kid who's seriously injured and they kind of regress to a 2-year-old and they become combative and they vomit, and it can be a very, very emotionally stressful scene to deal with, especially if your helpers, people that are around you, are also freaking out. Then it really turns into a bit of a nightmare. Now, obviously there are anatomical differences on kids, infants, children, toddlers, and things like that. We talked about the airway anatomical differences with the tongue and the epiglottis being larger and the back of the head being larger, so you have that concern. You have to put some padding behind the shoulders. And of course, because their ribs are more pliable, they're more cartilage than they are bone, they're more flexible, so ribs can, if they do get struck in the rib cage, the ribs can deform and then spring back without fracturing, unlike an adult. And of course, the abdomen is less protected. I don't know if you ever noticed this. You got this little, 18-month-old, maybe 2-year-old little kid standing in front of you, and their belly's sticking out. It looks like they've got a beer gut or something. And that's because their abdominal muscles are very weak, and their abdominal organs are kind of big, and they're kind of just sticking out. Well, of course, they'll outgrow this, but it just makes their abdominal cavity, their thoracic cavity, just more prone to injury, for especially blunt force trauma. When it comes to physiological considerations, their oxygen stores and glucose stores are very low. So even though you get there and the child's stable and seems to be doing okay, they only have so much oxygen stores, unlike adults, and glucose stores. So they do have a tendency to crash more quickly, meaning they're stable initially, and then within a few minutes that they start to deteriorate and go into, and deeply into shock. So we want to get there, be aggressive with our oxygenation, keep them warm, treat their injuries as appropriate, and get them to the appropriate hospital. And this is the same thing, this is rapid transport. So you treat the ABCs, you treat the uncontrolled bleeding, you treat the airway problems, you load them in the gurney, you drive fast, to the hospital or safely, fast. Go figure. Now, we have a whole lecture on pediatric assessments, and I know you've already learned how to assess an adult, meaning your primary assessment, ABCs. Hi, sir, my name's John, here to help you. Check ABCs, check all the pulse, the skins, and all that stuff. On little children, infants, toddlers, young children, maybe, and there's really no age consideration, maybe under the age of 10 possibly, we use what's called a PAT. And this patient assessment triangle, as we look at these three considerations, and we can do this from a distance as we're walking up to the patient, either laying on the ground over there from 10, 12, 15 feet away, we can assess a lot of this. So basically, the general appearance is their level of consciousness. Are their eyes open? Are they moving around? Are they interacting with their family or their friends or the firefighters or the police officers? Or are they unconscious or are their eyes closed? Then we look at their work of breathing. And that means, are they breathing in a labored manner? Are they not breathing at all? How good or how bad is their breathing essentially? Are we going to have to intercede in their breathing? And then we also look at circulation. What's the color of their skin? So is it blue? Is it pink? Is it gray? You guys get the idea. So if you have somebody who has fairly effective work of breathing and their skins are pink, warm, and dry, but they appear to be asleep or not responding to you, it's probably a pretty stable patient. If you have a person who's has a general appearance of being totally normal, they're interacting well, but their skins are a little cold, they're a little clammy, they're a little blue, but their work of breathing is fine, you probably have a fairly stable patient. So the more of these triangle sides that are bad, the worse off the patient is. So if this person is unresponsive, not breathing effectively, and has cyanotic skins, that's probably the worst case scenario. So we use this triangle in place of what you've learned so far with the adult assessment. Pretty much the same idea, just different terminology. So you treat them the same way. They are human beings, even though they're small human beings. So we're going to do the spinal motion restriction if necessary. We're going to ABCs, control any bleeding, and of course keep them warm, especially infants. Infants lose heat very rapidly. So keep them warm, turn the ambulance at 85 degrees, and transport to the appropriate hospital. Now with geriatrics, auto collisions are fairly common. It's the second most common cause of trauma in the elderly population. And we've already talked about, I'm sure, multiple times about the anatomical considerations. If you think about, their bones are brittle due to osteoporosis. They can have all kinds of pre-existing conditions called comorbid factors, hypertension, high cholesterol, heart problems, diabetes, all those things. And of course, their vision might not be as good, their balance might not be as good. So you can see where there's a number of problems, makes them more prone to succumbing to these injuries possibly. Remember too that they're probably on medications like some kind of beta blocking medication or blood thinning medications. And if they're on a blood thinning medication and or a beta blocker like a atenolol or propranolol or metoprolol, then these medications reduce their chance of compensating if they do go into shock. So they might start to go into shock. You might not notice it because of, especially the beta blockers can block the heart rate from going up. So you might not notice this person's heart rates. Normally heart rate should be high if they're in shock, but because of the drug, it's keeping it down. So you might miss the fact that they're going into shock. And remember, these people who are 65, 75, 85, 90 years old, they probably have hardening of the arteries and also have hypertension. So 120 over 80 is not normal for them. If they're not on a blood pressure medication, more than likely they would be hypertensive. 160 over 90, that would probably be their normal blood pressure, somewhere in that neighborhood. So you arrive on scene, you got this lady right here in this car, and her blood pressure is 110/70. She's probably in shock, even though for you or I, 110/70 would be great. But for her, it's probably too low. And the number one cause of injury in old people is are falls. Number one thing, they fall off of things, they hit things, and again, their bones are very brittle. They fracture in a fall that you might take and get up and walk away. They'll break their hip or their femur. And again, you look at you talk about those comorbid factors, altered mental status. For that, you'd have to know their baseline. So if they have a friend or a relative nearby or a caregiver nearby, you'd want to ask them, what's normal for Maud? What's her baseline level of consciousness? What's changed, or has anything changed today? What I'm seeing here. Remember, communication could be an issue as well. Not just vision, hearing, speech, or even building a rapport with the person to gain their trust can be an issue as well. And the rest of it's, pretty much the same thing. Rapid transport, spinal stabilization. Remember to pad the voids really well if you're going to put them in some type of spinal stabilization or put them on a spine board. And again, they are also, all these patients are prone to hypothermia, especially the elderly population, because their hypothalamus isn't working quite as well as it did when they were younger, and rapid transport to a trauma center. And here's, you can see some of the complications. We covered this already before. The kyphosis, the scoliosis, the lordosis, all those back problems that people have with aging process makes it a lot harder to put them in spinal motion restriction. These people, if you had to put them on a spine board, you'd have to pad. You can see that void between the back of their head and the board itself. Even on the gurney, even if you put them onto a gurney, you'd still have to put a collar on them somehow, a soft collar or a stiff collar, and you'd have to get a pile of blankets, and you'd have to create some kind of padding behind that head. Otherwise, it's pretty much useless. Now, a scenario, you're called to an adult daycare center. You have a 23-year-old female who's fallen down a flight of steps. This person has Down syndrome, and this changes the complexity of the call considerably for a number of reasons. One, they're normally not usually very communicative with strangers. They usually have a caregiver or a family member with them, or someone they trust. They have a heightened sense of pain, so the slightest scratch or the slightest boo-boo will make them scream and scream and scream. They can become really, really combative out of fear. Not that they don't like you, it's just that they're scared, they don't know what's going on, they're hurting. Their senses are very sensitive, I guess is the way to put it. So this is the call you're going to spend some time on. You're not going to scoop and haul, rush to the hospital, because it's just going to be a nightmare. We try not to restrain these people if we possibly can. That's our last resort because it's so traumatic for them. But if you absolutely have to, there's no other way to getting this person to the hospital, and they've got to get to the hospital due to their injuries. It's going to take you a little bit to do it, but you might have to restrain them. Now, it's not just the Down syndrome, people with dementia, autistic patients, and depending on where on the spectrum the autistic patient is, how high functioning they are, might make a big difference in how the call goes. I've had students that were high functioning autistics, very, very smart, brilliant students, and I've had patients who were at the very low end of the spectrum that were very combative and they didn't know what's going on. So it just depends on where they are on the spectrum. People with brain injuries or previous brain injuries, so they have some kind of brain trauma which led to permanent brain damage, and now they're acting almost autistic or demented sometimes, and they might not be able to speak or understand what's going on, and they get combative. People with strokes, the people after they have a stroke, they can have permanent cognitive changes. Alzheimer's patients, they go through phases of Alzheimer's. They go through periods of Disorientation, of course, but even more disorientation. Sometimes they get violent and they can't comprehend what's going on, so they lash out. So it becomes a scene safety issue for us. Again, we try not to restrain these people if we possibly can, but sometimes we might have to. What it really comes down to is don't rush, take your time, talk to the caregivers. More than likely, unless you're just an unlucky, EMT, you're going to have someone there who knows this person, and that person knows how to talk to this person, speaks their language, so to speak, and is able to communicate and calm the person down. You would definitely want to take that caregiver, helper, family member with you to the hospital in the back of the ambulance with the patient, just as if it were a mother and a child, to keep this person calm. If you don't have to get a blood pressure, if you don't have, if you think getting a blood pressure and doing a full assessment is just too much for this person, that's fine. It's better to get them to the hospital, and you're just explaining your documentation that the patient would become agitated and with any kind of stimuli like that. Just document the fact that you decided not to do it. You can get a pulse, you can watch the respirations, you might get a pulse ox on them, you could maybe get a blood sugar if you think it's necessary, but again, that might be really invasive, and the person might really react to that. So use your own best judgment on these, but I've transported these patients. I didn't get a single vital sign on them just because it's just easier to get them to the hospital, and which is what they really need. They need to talk to a doctor or be seen by a physician. So we're done with chapter 36.